We have discussed about the pathogenesis, the basics of tuberculosis and how to diagnose a case of pulmonary and extrapulmonary TB, right. So, now let us discuss tuberculosis treatment. So, there are two types of pulmonary or extrapulmonary tuberculosis. One is drug sensitive and another one is drug resistant. In your course, you have to know drug sensitive TB in detail, treatment of DSTB in detail. And in case of in DRTB, regarding DRTB, I will just discuss the important two drugs, bedaquiline and delamanid. Okay. So, not the full regimen here. Now, this is the diagnostic algorithm for diagnosing in a case of DSTB, drug sensitive tuberculosis, right. So, what is presumptive tuberculosis patient? What is it? Who is a presumptive tuberculosis patient? So, a patient with fever, persistent fever or cough for more than 2 weeks or hemoptysis for more than 2 weeks. This is defined. They are defined as a case of presumptive tuberculosis patient. So, in all cases of presumptive TB patients, so you will order an X-ray, chest X-ray and sputum smear examination, right. So, there may be 4 scenarios based on the investigations. The patient may have sputum smear positive and X-ray suggestive of tuberculosis, smear positive X-ray not suggestive of tuberculosis, smear negative X-ray suggestive of tuberculosis and smear negative X-ray negative, right. So, this may be there may be the 4 scenarios. In case of these 2 scenarios where the smear is positive, regardless of X-ray is positive or not, we can call it as microbiologically confirmed tuberculosis, pulmonary tuberculosis, fine. So, I am discussing here about the pulmonary TB, and in case of the other 2 scenarios where the X-ray, the sputum smear is negative but X-ray is suggestive, or sputum smear is negative, X-ray is also negative and you are still suspecting this is a case of tuberculosis. So, these 2 segments are termed as clinically diagnosed tuberculosis. Okay. So, in that case, if the sputum smear is negative, X-ray is suggestive. So, maybe you should order a fresh sputum sample. Maybe the sputum sample collection is erroneous, right. So, you should order a fresh sputum sample, and in case of sputum smear negative and X-ray negative patient, first you have to rule out the other possibilities, other diagnosis rather than TB. Exclude all other possibilities, then you can order anti-tubercular drug, right. So, in those cases sputum smear positive, all the sputum smear positive cases, that means the pulmonary TB that is microbiologically confirmed, we should order CBNAAT in all cases of sputum smear positive TB. Why? Because India and Africa are the 2 countries where there is a plenty of numbers of DRTB, drug resistant tuberculosis. So, to detect at earliest, we should order CBNAAT in each and every patient of microbiologically confirmed tuberculosis, fine. So, if CBNAAT, so in CBNAAT we can, the result can be divided into 2 parts. First one is MTB complex detected or not, second one is rifampicin sensitive or not, or rifampicin resistance detected or not. So, there are 2 parts of the report. First one is MTBC detected, yes, in all cases of microbiological confirmed TB MTBC should be detected, and rifampicin sensitive or not, that is defined, that is determined by the proliferation, or you can say it the PCR technology, via PCR technology you can amplify the RPOB gene sequence. If that is present, RPOB gene, that means the sample is resistant to rifampicin. You can call it as RR or DRTB itself, right. MTB detected and MTB not detected, right. And another one report may come, rifampicin resistant indeterminate. So, that means you should repeat the sample. you should send the sample again for CBNAAT examination. Okay? And if the smear is rifampicin resistance, right, in that case you should order which test? Which test? LPA, right, LPA, line probe assay, to detect further first line resistance, drug resistance, right. If that is isoniazid and rifampicin resistance, you can call it as MDR tuberculosis. Okay. So next, what is presumptive TB? I have already mentioned, and you have correctly answered the definition of presumptive tuberculosis. So now case definition, microbiologically confirmed TB, that means sputum smear is positive, maybe in culture, maybe in smear, maybe in CBNAAT. Okay. Next one is clinically diagnosed TB, smear is negative but X-ray is suggestive, or the symptoms are highly suggestive of tuberculosis. And in children, specifically children age less than 5 years, they cannot expectorate sputum. And in those cases, the positivity of sputum smear is also very less, the sensitivity is very less. So in case of children less than 5 years, you can rely upon the clinical examination, you can rely upon the X-ray and Mantoux test, TST, tuberculin skin test, right. Okay. So now another case definition, this is very important, you have to know each and every detail, right. So what is a new case? New case, that means tuberculosis, microbiologically confirmed TB, or any form of tuberculosis that is diagnosed as at earliest as a new case, right. So what is previously treated patient? That means the patient received anti-TB drug for more than 1 month, more than equals to 1 month, 1 month or more. What is recurrent TB cases? That means the patient was treated successfully in recent course, but again after and subsequently he was declared cured after the treatment, but again the patient was infected with tuberculosis. This is called recurrent TB case. Treatment after failure, that means the patient became positive, even became positive even after the 6 months course therapy of tuberculosis. That means this is a case of failure, treatment after failure. This is different from the recurrent, right. So in case of recurrent TB, the patient was declared cured previously and again the patient was infected with tuberculosis. And treatment after loss of follow-up, that means the patient was received more than 1 month's therapy, tuberculosis therapy, followed by the patient never came back to you, or the patient there is no follow-up after that. There is no sputum smear examination, even the patient didn't take the drug. And this is a classification based on drug resistance, mono drug resistant, that means any one of the first line agent, a resistance to the any one of the first line agent. Next one is PDR, that means polydrug resistance. What is polydrug resistance? That means more than one first line of anti-TB drug. Maybe isoniazid rifampicin, maybe another one, pyrazinamide ethambutol, maybe this sequence, right. What is MDR? Multidrug resistance. Mind it, one thing is that PDR, in case of PDR, except isoniazid and rifampicin, INH and R, the other two drugs, ethambutol or pyrazinamide, this is called PDR. And MDR, that means, yes, isoniazid and rifampicin resistance. And what is XDR? That means MDR plus any fluoroquinolone plus any injectable, right? Amikacin, kanamycin, capreomycin, any one of these, right? So this is called XDR. What is pre-XDR? Pre-XDR, only fluoroquinolone, isoniazid, rifampicin and only one fluoroquinolone, not the injectable. 2-HRJD plus 4-HRE. 2-HRJD, that means 2 months of, this is called intensive phase, and another one 4 months is called continuation phase. So 2 months of HRJD, that means isoniazid, rifampicin, pyrazinamide, ethambutol, 2 months. followed by 4 months of HRE, right? Isoniazid, Rifampicin and ethambutol. So this is the short course regimen, this is the DSTB regimen. But recently one regimen has been approved, but this is in pipeline actually. H isoniazid, P, that means rifampicin, moxifloxacin and pyrazinamide, HPMZ regimen. This is a 4 months course regimen. 2 months of HPMZ followed by 2 months of HPM. Okay? So total 4 months of regimen. This is a newly approved regimen. To refer the patient, when we diagnose a case of TB, then we should refer the patient to NTEP DOTS center. What is NTEP? National Tuberculosis Elimination Program, right? So previously it was termed as RNTCP, now it is known as NTEP. So we should refer the patient to NTEP DOTS center. That means the patient can procure the medicines and can follow up in the near hospital, near actually health centers, even RH, rural health center, even PHC or BPHC itself. Okay? So actually we should make the treatment accessible to the patient. We should not we should not say the patient that you should come over and over again to procure the patient from here. No need of that, because that actually decreases the adherence and compliance of the drug and emergence of drug resistance. So to combat that, DOTS has been introduced. What is the full form of DOTS? Directly observed treatment short course, right? That means directly observed. The treatment providers, maybe Asha Kormi or any healthcare providers, so they ki kore tara kono idea? Actually they supervise the medicine intake. They advise the patient to take the pill in front of their supervision. Okay? So that's why this is directly observed. That ensures the patient should not miss any one of the pill. Okay? And another one is new initiative of Government of India is 99 dot strategy. Any idea what is that? This is a potential MCQ. 99 dots. The strip, আমি দেখাচ্ছি stripটা. Okay, I'll discuss later. Okay, fine. So next one is, so this is okay. Yes, IP phase, that means 2 months of IP, 56 doses. I have already mentioned, and 112 doses of CP, continuation phase. Why Z is not there in CP? Why pyrazinamide is not there in CP? Any idea? Any idea? Why pyrazinamide is not there in CP? I'll talk later, I'll discuss about it later. No, actually the thing is that during the early 2 months or early 1 month of tuberculosis, the TB bacilli are much more active, right? So they proliferate inside cell and the cell become more acidic. Pyrazinamide actually works inside the cell in intracellular bacilli, against the intracellular bacilli in acidic environment. That is the reason after 2 months the acidic environments will be gone. That's why there is no role of pyrazinamide after 2 months of therapy. So this is the packet of DOTS therapy, anti-TB drug therapy. 4 FDC regimen, 4 FDC, that means fixed drug combination regimen, 4 FDC and 3 FDC. 4 FDC in IP and 3 FDC in CP, right? 4 that means HRJD and 3 that means HRE. Okay. So this is the packet of the drug therapy, right? So দেখ এখানে আছে, there is a call mark, right? Telephone mark after the alternate dose. After peeling of the strip, the patient can find a number underlying the strip, written underneath that strip. So they have to give a missed call in that telephone number that is registered. So that ensures the patient has not missed any of the pill. This is 99 dots strategy, right? So each of the patient, each of the tuberculosis patient, mind it, each of the tuberculosis patient may be clinically diagnosed or microbiologically confirmed or extrapulmonary, any of the TB patient. You have to refer all of the patient to NTEP dot center. One reason is they will give a Nikshoy ID to every patient, right? Unique ID number. Second one is they follow up regularly and ensures the treatment adherence. So this is the drug dose regimen of ATD. So HRJD এরকম করে মনে রাখবি 5, 10, 25, 15, 5, 10, 25 and 15 mg per kg. This is the weight based drug regimen. Okay, 5, 10, 25 and 15. Okay, HRJD. And in case of pediatric dose calculation, you can add 5, 10, Isoniazid 10, Rifampicin 15, Pyrazinamide add 10, 35 and ethambutol 20. Easy, okay? And this is streptomycin. Yes, streptomycin is not used nowadays, right? So previously the regimen was HRJDS, but streptomycin, actually streptomycin is bacteriostatic. One second, আমরা দেখেছি there are various studies regarding role of streptomycin as ATD, but আমরা যেটা দেখেছি HRJD is sufficient and streptomycin can be omitted safely. Second reason is that streptomycin should be given in as IM injection, so that is definitely painful. Okay, and এইটার জন্য আগে কি হতো, পেশেন্ট ডিফার্ড হতো, পেশেন্ট আসতো না ইনজেকশন টিবি ট্রিটমেন্ট নিতে. So that's why the NTEP has omitted the streptomycin from the regimen. But streptomycin has some role in some cases of tuberculosis, specifically in case of CNSTB and skeletal tuberculosis. Streptomycin can be given. So first, a patient when actually attends the DOTS OPD, clinical evaluation, for detailed clinical evaluation should be there. Weight, height, age definitely you have to mention. Second one is any comorbidities, diabetes, HIV, if the patient is having any comorbidities. If the patient is taking oral contraceptive pill, this is important. Why? Very good, Rifampicin, because of the Rifampicin, because this is an enzyme inducer. Okay, so these all histories you should take when you are listing the case as a newly diagnosed case. Okay, and this is very important, substance abuse, you should address the substance abuse. Okay, so simultaneously you have to send the patient for rehabilitation if the patient is addicted with some drugs. So this is the weight based category, এটাও মনে রাখবি, এটা কিন্তু important, 25 to 34, right? So 35 to 49, 50 to 64, 64 to 74 and more than 75. 2 to এরকম করে মনে রাখবি, 2, 3, 4, 5, 6 tablets FDC, this is FDC, 2 FDC, 2 tablets of FDC, 3 tablets of FDC, 4 tablets. This is the regimen. This is difficult, মনে রাখার দরকার নেই, পেডিয়াট্রিক টিবি রেজিমেন্টে একটু ডিফিকাল্ট আছে, মানে অ্যাডাল্টের সঙ্গে অ্যাড করতে হয়, দরকার নেই মনে রাখা, জাস্ট অ্যাডাল্টটা মনে রাখবি তাহলেই হবে. ওকে, সো These are the list of anti-tubercular drugs, specifically second line ATT. Okay. So first line are these 4: ionized rifampicin, pyrazinamide and ethambutol, and second line are class A or group 1, group 2, group 3, A, B, C you can give. So A, that means 3 drugs in A: bedaquiline, levo or moxi, and another one is linezolid. Very good, 3 drugs. Second, in group 2 or group B, 2 drugs, 2C, cycloserine and clofazimine. Okay, and the last one in group C, the rest of that means ethambutol, ethionamide, amoxicillin, piperacillin, meropenem itself, imipenem, right, and delamanid, PAS, right, para-aminosalicylic acid. So these are the groups of anti-tubercular drug. Okay, so now isoniazid. So any idea how isoniazid works? Isoniazid, actually isoniazid is a prodrug. It is activated to isonicotinic acid. This is an active form via catalase peroxidase enzyme. So this reaction, isoniazid to isonicotinic acid formation, leads to increase of reactive oxygen species that inhibits the mycolic acid formation. That is the part of the cell wall, right? So this is a bactericidal agent. Isoniazid is a bactericidal agent. So regarding pharmacokinetics, rapidly, completely absorbed, right, may be given in IM or oral form, intramuscular or oral form. Okay, and metabolism, yes, metabolism inactivated via, this is very important, via acetylation in liver. So metabolism of isoniazid is done via acetylation. This is why this is important, because this acetylation leads to increase of production of hepatotoxic radicals, hepatotoxic metabolites that damages the liver. There are 2 types of acetylators, one is fast and one is slow. So in those patients who are the fast acetylator, who acetylates very fast, so in that cases they are more prone to develop hepatotoxicity than the slow acetylators, right. So this is very important in isoniazid. Fast acetylators are prone to develop more hepatotoxicity, slow acetylators prone to develop less hepatotoxicity. So elimination is mostly via urine and small amount via saliva and feces. What is the most common adverse drug reaction? That is peripheral neuropathy, right, because hinders production of metabolism of B6, pyridoxine. So you have to give or supplement pyridoxine if you are giving isoniazid. Okay. Next one is hepatotoxicity. I have already mentioned pruritic rash and skin rash. This is very rare, but hepatotoxicity and peripheral neuropathy are more common. Even isoniazid toxicity can lead to convulsion, seizures, right, and metabolic acidosis, severe metabolic acidosis. So in that case, so the drug dose of the pyridoxine is 10 mg along with the isoniazid, right. You have to give 10 mg pyridoxine. But if the patient is developing INH toxicity like convulsions or metabolic acidosis, then you have to give pyridoxine up to 100 mg. This is a therapeutic dose and this is the preventive dose of pyridoxine. Okay. So now rifampicin, any idea of mechanism of action rifampicin? DNA, you have heard about the DNA dependent RNA polymerase, right? This is an enzyme. So Rifampicin inhibits the DNA dependent RNA polymerase. Okay, and it is encoded by RPOB gene, as I have already mentioned. So DNA dependent RNA polymerase, and this is also a bactericidal agent against the intra and extracellular bacilli, right? So absorption, rapidly absorbed via GIT, and definitely in case of INH and rifampicin, both these drugs, their absorption is reduced when it is you are taking the drug with the food. So food hampers their absorption. That means you should advise the patient to take the pill in empty stomach. And rifampicin widely distributed throughout the body fluids, excreted through the body fluids like urine, like saliva and CSF also. So patient তোকে এসে বলবে যে আমার urine color orange হচ্ছে, tears are orange in color, right? So this is because of rifampicin. You have to counsel the patient that this is not harmful. Metabolism, this is an enzyme inducer, তাই তো এনজাইম ইনডিউসার। এটা যে রিজনের জন্য বললাম যে if the patient is taking OCP, then you have to advise the patient stop taking OCP and use the barrier method instead, right? And rifampicin should be continued. Another one is in case of patients with suffering from diabetes mellitus, their drug also can be, their metabolism of their drug also can be hampered by the rifampicin. So it is advised to switch to insulin therapy during the course of the this anti-TB drug. So elimination, specifically this rifampicin is eliminated by the bile route, enterohepatic circulation, bile route, feces and urine. So the ADR is, this is not an adverse drug reaction, but this is a statement. So this is not an adverse, right? Orange discoloration. Another one is yes, this is also hepatotoxic, but less hepatotoxic than INH. The most hepatotoxic one is pyrazinamide, followed by INH and then this one, rifampicin. Skin rash is very common. Thrombocytopenia, flu-like syndrome. This is important. So if a patient is taking rifampicin, then he or she might develop flu-like syndrome. The patient typically তোর কাছে আসবে বলবে আমার একটু জ্বর আসছে ডাক্তারবাবু, flu-like illness হচ্ছে. So that is typically because of the rifampicin. So to combat that, there is a regimen called intermittent rifampicin therapy. মানে একদিন গ্যাপে গ্যাপে rifampicin দেওয়া যায়, আরও অনেক থেরাপি আছে, এইগুলো করলে flu-like syndrome কিন্তু কমে যায়. And hemolytic anemia. So there are two types of anemia that is caused due to anti-tubercular drug therapy. One is hemolytic anemia that is caused by rifampicin, another one is sideroblastic anemia that is caused by pyrazinamide. এটাও MCQ কিন্তু. So pyrazinamide actually, this is an inactive form, activates to pyraginoic acid in an acidic environment. So আমি যেটা বললাম এক্ষুনি, it actually inhibits the intracellular bacilli proliferation inside the cell via production of pyraginoic acid. So this pyraginoic acid hampers the FAS synthesis, fatty acid synthase 1 enzyme, FAS1. So FAS1 is inhibited by the pyraginoic acid. That kills the bacteria. And absorption rapidly from GIT, metabolism predominantly hepatic. So this is hepatotoxic one. This one, 5-hydroxypyrazinamide is toxic to liver, okay, and eliminated via kidney, renal route, right? So two drugs predominantly eliminated via renal route, via glomerular filtration. One is pyrazinamide and second one is ethambutol. So in case of kidney disease, chronic kidney disease or acute kidney injury, you have to alter the regimen. Pyrazinamide and ethambutol you have to give in alternate day, and isoniazid rifampicin daily. So most common adverse drug reaction is hepatotoxicity, hyperuricemia, sideroblastic anemia. This is important, hyperuricemia. So very frequently the two main complaints of the anti-tubercular drug receiving patients. One is hepatotoxicity, second one is skin rash, third one is this one, uric acid, hyperuricemia. The patient typically complains about the gouty pain of joints, different small and large joints, after taking this therapy, this ATD. This is because of pyrazinamide. So pyrazinamide, the active form of pyrazinic acid, it competes with the xanthinic acid, right? So pyrazinic acid eliminated via kidney, but xanthic acid not. That means it is accumulated and increases the chance of gout formation. So you should give the uricosuric acid drug like probenecid. ইউরিকোসুরিক দিলে কি হবে, xanthinic acid বেরিয়ে যাবে, তো গাউট কমে যাবে, ঠিক আছে। So there is neither the mechanism of hyperuricemia is not because of the increased production of the uric acid, but decreased elimination of the uric acid, right? So febuxostat or allopurinol দিয়ে কিছুই হবে না, তাই তো, কারণ এলিমিনেশন তো করতে পারবে না। Sorry. So next one is ethambutol. Ethambutol is a bacteriostatic drug. So arabinogalactan is the target of the ethambutol. It is a bacteriostatic drug, and along with the INH, it actually increases the effect of INH. Okay, because both of these drugs are coded by the similar gene CAT-G and INHA. Okay, and pharmacokinetics, definitely this is the pharmacokinetics and metabolism. This is important. The ethambutol is metabolized to aldehyde adducts formation. So these aldehyde adducts are toxic to the optic nerve. Okay, so that is the reason ethambutol can cause blindness, sorry, optic neuritis, color blindness, and these things. So main adverse reaction of ethambutol is optic neuritis, blindness, and skin rash. Okay. So how to follow up a patient of tuberculosis, sputum smear positive tuberculosis. So in case of pulmonary TB, the sputum smear examination should be done at the end of IP and at the end of CP. This was the sorry, this was the previous regimen, but recently NTEP has advised to lengthen the follow up. That means, see, after 6 months, after the end of the CP, after 6 months, after 12 months, and after 24 months also. This long follow up ensures the patient is not infected with the TB again and the patient is cured. There is no failure of treatment, right? Weight measurement, and in case of EPTB, the follow up depends upon the site of extrapulmonary TB. That means if the patient is having, suppose lymph node tuberculosis, then you have to assess the size of lymph node. But mind it, in case of lymph node tuberculosis specifically, after 3 to 4 months of initiation of TB, initiation of anti-tubercular drug, the size of lymph node even may not decrease, even can increase further, right? This is called paradoxical reaction. But after 4 months, 3 to 4 months, the size will reduce. So in case of lymph node tuberculosis, measure the size of lymph node. In case of pleural effusion, reaccumulation of fluid or any non-absorption of pleural fluid. In case of CNS tuberculosis, look at the symptoms. Do not do LP again, do not do lumbar puncture again. In case of skeletal tuberculosis, look at the symptoms and the skeletal formations, right? So weight gain, definitely decrease or increase of symptoms and appearance of new nodes. This is important, appearance of new node. Even after 3 to 4 months of ATD, if the lymph node size is not decreasing and or appearance of new node at new site, Then you must think about, one is alternative diagnosis, second one is drug resistant tuberculosis. We have to do the biopsy again, lymph node biopsy again, and send for culture. These are the most common side effects of, the most common two side effects. There are plenty of side effects of ATD, but the most common two side effects are, one is skin rash and second one is hepatotoxicity. So if the patient is developing hepatotoxicity, so you should stop the regimen or you should continue. Suppose তুই একটা পেশেন্টকে স্টার্ট করলি ATD, after 2 weeks of follow up, always after 2 weeks order an LFT in each and every patient. After 2 weeks of follow up, you are seeing that LFT is deranged. How much deranged? That is very important. If the SGPT and SGOT is more than 5 times of upper limit of normal without symptom, or 3 times of upper limit of symptom, upper limit of normal with symptoms. Clear? The normal level of SGPT, SGOT is around 40 to 45. So if the patient is having jaundice or pain abdomen and recurrent vomiting with the SGPT, SGOT level of at around 120, 130, you must stop the drug. But whether in case of in 120 and 130 regimen, in the range, if the patient is asymptomatic, you do not have to stop this therapy. So in that cases you have to stop the ATD and you have to order, you have to give the alternate regimen, hepato-safe regimen. What is that? Stop all the drugs first. Stop all the drugs. Start LE regimen, that means levofloxacin and ethambutol. These two are the hepato-safe regimen. LE regimen, order LFT after 1 to 2 weeks after this therapy. Okay? Then follow up with symptoms, if the symptom is decreased or not, and if the SGPT, SGOT level is less than 2 into upper limit of normal. Suppose the SGPT, SGOT is 70 and 80, at the range of 70 and 80. Then you can reintroduce one by one, not all along, one by one regimen. First you have to start Isoniazid, maybe at a very low dose or maybe the full dose, maybe 100 once daily, or then titrate the 300 once daily. Follow up with the repeat LFT. Okay, yes, it is normal. Re-challenge with Rifampicin. Okay, 450 OD. That means never give Pyrazinamide. Okay, but actually কোনো স্টাডিতে বলে পাইরাজিনামাইড দিলেও কিছু হয় না, কিন্তু আমাদের এখানে একটা এজোল স্টাডি বা এজোল একটা প্র্যাকটিস, সেটা হচ্ছে পাইরাজিনামাইড দেওয়া যায় না। Pyrazinamide is most hepatotoxic. So the final regimen will be HR and E, omit the levofloxacin, HRE for 9 months. This should be the regimen, hepatotoxicity. Okay, and in case of, and definitely always check other causes of liver failure, like the patient is having chronic liver disease or not, alcoholic liver disease or not. Okay, next one is skin rash. So the most common side effect of which drug is skin rash? That is ethambutol. So the incidence of skin rash due to ethambutol is more than other drugs. So HRJD, the skin rash is more in ethambutol than pyrazinamide, than R, than H. So from the backward. Okay, so stop the drug, all drugs, and reintroduce from INH. INH is the least, has the least incidence of skin rash. From INH, low dose 50, 100 and 150, then 300, followed by Rifampicin sequentially, followed by Pyrazinamide and ethambutol. So actually in all cases of drug rash, in all cases of skin rash due to ATD, you have to order a drug sensitivity test, drug allergy test. বলা তো কোনো পেশেন্টের হয়তো ইথাম্বিউটল অ্যালার্জি নেই, পেশেন্টের হয়তো আইসোনিয়াজিড অ্যালার্জি, যদি ওটা চলে আসে তাহলে ওই রেজিমেন থেকে দিতে হবে উইথ মানে আইসোনিয়াজিড বাদ দিয়ে, ঠিক আছে, এইভাবে চেঞ্জ করতে হয় রেজিমেন। ওকে, নাও ট্রিটমেন্ট আউটকাম, যেগুলো আমি অনেক কটা বললাম। কিওর, দ্যাট মিনস আফটার সিপি the smear is negative, that is cured. Treatment completed, completed the treatment and was declared cured. Okay, failure, that means specimen is still positive after the end of the treatment. Loss to follow up, that means interrupted after 1 or more months of having therapy. Not evaluated, that means cannot be assigned and transfer out. Treatment regimen changed, that means in subsequent follow up the patient is found to have DRTB. So from DS to DR, the treatment regimen changed. And the most important is other comorbidities, যেটা আমি বললাম এক্ষুনি, diabetes mellitus. First one, so the most important 2 comorbidities that may hamper the TB outcome, one is diabetes and one is HIV. So in case of diabetes mellitus, why? Because the diabetes mellitus is a basically immunocompromised, immunosuppressed state that increases chance of treatment failure, drug resistance as well, right? And so in case of all TB tuberculosis patient, we have to check whether the patient is having diabetes or not, and change the regimen, change the oral therapy to the insulin therapy. Okay, and always give Benadryl or pyridoxine, because the diabetes mellitus patient are already actually suffering from some sort of neuropathy, peripheral neuropathy, diabetic neuropathy actually. And furthermore, if you are giving a pyridoxine, if you are giving Isoniazid, then it may worsen the neuropathy. So we have to give the pyridoxine. And next one is TB and HIV. This is important, because why this is important? Because আমি যেটা বলেছি, তোদের কোনো আইডিয়া যে in case of clinical course or types of tuberculosis in HIV patients কিরকম ভাবে হতে পারে? Regarding the CD4 count, suppose CD4 is less than 200 and more than 200. So less than 200, that means more immunosuppressed, the chance of disseminated TB is more, and drug resistant TB. And in case of more than 200 CD4 count, that is same as that of the other tuberculosis patient, microbiologically confirmed TB patients. So definitely TB can appear at any stage of HIV infection, and presentation varies with the stage, that means CD4 count. And this is important. IRIS, জানিস IRIS কি? What is IRIS? IRIS. সাপোজ আচ্ছা একটা এক্সাম্পল দিচ্ছি, সাপোজ তোর কাছে একটা পেশেন্ট এলো, পেশেন্টের বেসিক্যালি টিবি হয়েছে, মাইক্রোবায়োলজি কনফার্ম টিউবারকুলোসিস, অ্যান্ড ইউ হ্যাভ অর্ডার্ড এ রুটিন টেস্ট, HIV test. HIV is positive. Now what to do? You have to start the ATD or ART. You have to start ART, right? CD4 count and ART. Which is before that? Before ART, ATD should be started, or vice versa? Which one? ATD should be started first. Because why? Because if you are starting ART, antiretroviral therapy, তখন কি হবে? হ্যাঁ বল না, CD4 count নয়, বেসিক্যালি reactivation of the CD4 count normal হয়ে যেতে থাকবে, reactivation of the CD4, reactivation of the immune system. So that reactivation of the reactivated immune system যে টিবি ছিল তার এগেনস্টে অনেক বেশি রিয়াক্ট করবে, that may be flaring up the tuberculosis. So first you have to kill the bacilli, you have to administer ATD first, after 2 to 4 weeks of that start ART. Okay, so this is called IRIS. What is the full form of IRIS? Immune reconstruction inflammatory syndrome. Okay, so IRIS, that means immune reconstruction হচ্ছে, তার জন্য একটা সিনড্রোম হচ্ছে, this is IRIS. আইরিসের দুটো টাইপ আছে, ওয়ান ইজ প্যারাডক্সিক্যাল রিয়াকশন অ্যান্ড ওয়ান ইজ আনমাস্কিং of iris. Paradoxical reaction, that means suppose the patient is having pleural tuberculosis, pleural effusion, okay, and due to iris the patient may develop lymph node, new lymph nodes. This is called paradoxical reaction, মানে নতুন অন্য কোনো সাইটে আরেকটা কিছু অ্যাপিয়ার হলো। and unmasking, that means the previous one বেড়ে যাচ্ছে, যেটা lymph node এর সাইজ বেড়ে গেল, okay. These two types of iris is there. This is very important, এটা তোদের কমিউনিটি মেডিসিনের টপিক। এখন কি কমিউনিটি মেডিসিন চলছে তোদের? বল তো, এটা জানিস এটা? 3 eyes of TB HIV, what are the 3 eyes of, এটা তো খুব ইম্পর্টেন্ট কোশ্চেন কমিউনিটি মেডিসিন। One is ICF, intensified case finding strategy, that means in all cases of HIV we should screen tuberculosis at intensified regimen, right? Actively, মানে actively করতে হবে, প্রত্যেকটা পেশেন্টের স্মিয়ার এক্সামিনেশন করতে হবে, এক্স-রে করতে হবে, right, to rule out tuberculosis. This is called ICF. Second one is ICAIC. ICAIC, that means infection control, airborne infection control actually. That means you have to stick to the plan that airborne infection cannot transmit, specifically in case of tuberculosis. And third one is IPT, Isoniazid preventive therapy. In all patients diagnosed with HIV, you have to rule out active tuberculosis first, then you have to give Isoniazid preventive therapy, 6 months of Isoniazid, okay. But খুব important যেটা, you have to rule out active TB. If the patient is not having active TB, then start the IPT, Isoniazid preventive therapy. এটা কিন্তু ইম্পর্টেন্ট, তোদের ইয়েরও কমিউনিটি মেডিসিনের কোশ্চেন আছে, ওকে। সো নেক্সট ওয়ান ইজ চেঞ্জ অফ রেজিমেন। সো রিফাম্পিসিন ইজ অ্যান এনজাইম ইন্ডিউসার, রাইট? রিফাম্পিসিন should be changed to rifabutin or rifapentin, okay. Instead of rifampicin, these agents can be used. One. Second one is, তোদের আচ্ছা এখন নতুন HIV রেজিমেন কি? TLD, tenofovir lamivudine dolutegravir. This is the new regimen. This regimen should be the same TLD regimen, but dolutegravir এর ডোজটা অ্যাডজাস্ট করতে হবে, right? Because dolutegravir 50 mg twice daily during the rifampicin therapy. ওকে, নেক্সট ওয়ান ইজ বেডাকুইলিন, যেটা আমি বলেছিলাম বেডাকুইলিন ডেলামাইড, আমি জাস্ট একটু টাচ করব বেডাকুইলিন। সো বেডাকুইলিন ইজ ক্লাস এ ড্রাগ, তাই তো, ক্লাস এ ড্রাগ। সো মেকানিজম অফ অ্যাকশন অফ বেডাকুইলিন, এনি আইডিয়া? এটা কিন্তু এমসিকিউ। দিস ইজ ওয়ান, মাইক্রোব্যাকটেরিয়াল এটিপি সিনথেজ ইনহিবিটর, বেডাকুইলিন, রাইট? সো বেডাকুইলিন, the new regimen, the new short course regimen of DRTB is B-PAL-M regimen. এটা মনে রাখবি, তাহলেই হবে B-PAL-M regimen. Bedaquiline, pretomamide and linezolid, moxifloxacin, B-PAL-M regimen. So in B-PAL-M regimen, this is the cornerstone of therapy, bedaquiline. The most important side effect of bedaquiline is QT prolongation followed by hepatotoxicity. ঠিক আছে? So before starting delamide or before starting bedaquiline, you have to see the ECG. If the QT interval QTC is more than 500 in case of male or more than 450 in case of female, then start cautiously bedaquiline and order ECG in follow up also. ঠিক আছে? And in case of what is delamide? Delamide inhibits the mycolic acid synthesis. ঠিক আছে? Delamide side effect more or less same, QTC prolongation and hepatotoxicity. This is the drug susceptible and drug resistant tuberculosis, একটা এরিয়াতে করা আছে, ঠিক আছে? এটা আমি দিয়ে দেবো, এটা দেখে নিচ্ছি। এতক্ষণ যেটা বললাম সেই একই সেম, আর কিছু নেই। And TPT, this is very important, or tuberculosis preventive therapy. What is that? Why we should give TPT? In which patient? Which kind of patient? কোনো আইডিয়া আছে? আমি আগের ক্লাসেও বলেছিলাম। Any idea of LTBI? latent tuberculosis infection? What is that? Only tuberculin test? Only tuberculin test and any other things? 4B, LTBI is very important. What is LTBI? So, from LTBI, if the patient develops, actually if the patient develops immunosenescence, immune dysregulation, then it can produce the active tuberculosis. So, TPT or tuberculosis preventing therapy, the role of the therapy is to prevent the LTBI to form the active tuberculosis. So, what are the indications of LTBI? First one is PLHIV. This is important. Children less than 5 years with household contact, যাদের অ্যাক্টিভ টিবির কন্ট্যাক্ট আছে তাদের দিতে হবে। এবং ইচ অ্যান্ড এভরি এখন যে রেজিমেন্ট সেটা হচ্ছে, আগে বলা হতো অনলি চিলড্রেন অফ লেস দ্যান 5 ইয়ার্স অফ হাউসহোল্ড কন্ট্যাক্ট অফ পিটিবি পেশেন্টদের দিতে হয়। এখন যেটা গাইডলাইন সেটা হচ্ছে ইন অল পেশেন্টস অফ হাউসহোল্ড কন্ট্যাক্ট ইরেসপেক্টিভ অফ এজ, যে কোনো এজে সমস্ত পেশেন্টকে, যাদের বাড়িতে টিবির পেশেন্ট আছে সমস্ত পেশেন্টকে কিন্তু টিপিটি টিউবারকুলোসিস প্রিভেন্টিভ থেরাপি অ্যাডমিনিস্টার করতে হবে। ঠিক আছে, অ্যান্ড অ্যালং উইথ দ্যাট পাইরিডক্সিন। Definitely rule out active tuberculosis before starting TPT. ঠিক আছে, and there are 3 types of monitor. Definitely monitor hepatotoxicity and adherence and other symptoms like peripheral neuropathy. And there are 3 regimens of TPT, tuberculosis preventive therapy. Previously it was only one, IPT. এই জন্য আগে যেটা বলছিলাম, আগে যেটা স্লাইডে দেখালাম, this was IPT and this is TPT. Because previously there is only Isoniazid preventive therapy, but Isoniazid, yes, you can give Isoniazid for 6 months. Alternatively, you can give Isoniazid with Rifampicin or Rifampicin, right? So the regimen will be shorter in case of Rifampicin, 3 months, okay? And Rifampicin monotherapy, yes, you can give for 4 months.